Good afternoon, everyone. It's my absolute pleasure to be introducing this and chairing this afternoon's session. My name is Professor Julie Sanders. I am Director of Clinical Research at St Bartholomew's Hospital and Cardiovascular Professor of Nursing at Queen Mary University of London. And I have the expertise of Hannah Moore, Manraj Sandhu and Emma Matthews, who will also be accompanying me to chair this session this afternoon. And we all give you a very warm welcome to the session, which is about communication, the present challenges and the future vision. We have a jam-packed afternoon for you, and we're going to kick off today with an extremely special guest. This is Cathy MacDonald, and Cathy is a former police officer, having served with the Police for Scotland for over 30 years. And for much of her service, she deployed as a hostage and crisis negotiator and was also responsible for training negotiators within the UK, as well as her international colleagues. Cathy speaks of her life as a negotiator as an intense but entirely rewarding and fulfilling role, and she enjoyed preparing and equipping her colleagues for the demands that the role would bring. Today, Cathy transfers those skills to meet the needs of her clients and takes the same pride and joy in helping others develop their knowledge and the use of consciously excellent communication skills. So I'm thrilled to welcome Cathy. I'd also encourage you to ask questions and to please put those in the bottom part of your screen where it says to include questions. And I will hand the floor over to Cathy. Thank you very much, Cathy, and welcome.
Thank you very much for the introduction. Now, I'm understanding that you've got control of the video behind the scenes, that you'll be able to press play. Is that correct?
Hello, I'm Cathy MacDonald from the Art of Communication, and I'd like to say thank you for inviting me to speak at your conference today. Now, I've been asked to deliver a presentation not only about communication that's fit for the challenges of today and the vision of the future, but a presentation that will give you some practical tactics that will help you when the pressure's on, time is tight, you're at the sharp end, and communication still has to be on point. Well, I hopefully have just the right thing for you. And if I said that I could offer you an element of within a communication framework that allowed you to communicate with anyone, anywhere, at any time about anything, that was fit for purpose at home, socially, and at work, that gave you a shortcut and a framework that you could rely on, that you could lean on no matter what, and also saved you a bit of time, then I'm hoping you'll say, yes, please give me some of that, because that's what I'd like to share with you today. Now, my world is from hostage and crisis negotiation, and like you, communication had to be on point when it mattered, and maybe even when there was lives at risk. And whether we were deployed to suicide intervention, where our ability to communicate, connect, understand and influence super quick was key, through to the other deployments at the other end of the spectrum, which would be hostages taken abroad. Now, that obviously wouldn't be something that was going to be solved in a few minutes. And in fact, sometimes it took years. Yet we needed a framework of communication that was fit for purpose, no matter our deployment. We needed something we could lean on, but had flexibility that allowed us to adapt. And that's what I'd like to share with you today. So it starts with this, with emotion. And I know that when I start speaking about emotion, there might be a tendency to think this is pink and fluffy and weak. And believe me, it's not. Everything about emotion within communication is pretty robust, and it's empowering when you can understand it, grab it, and make it work for you. And before I touch on how emotion impacts on communication, I'd like you to think about a time where you would say you were emotionally content, happy, and balanced, and compare that to a time where you were emotionally fueled and maybe even felt a little out of control, and then compare your communication in both situations. And that gives you a sort of lens to look at emotion and communication through, because emotion impacts on our pace, pitch, and tone, our choice of language and the words that we use, our ability or desire to listen, directly impacted by the intensity of emotion. And non-verbal communication, so those facial expressions, the hand expressions, and in fact, the whole body tells a story which is fueled through emotion. Emotion works far quicker than logic every single time, and there will probably be moments that you share with me where you thought, actually, in the back of my mind, logic tells me one thing, but emotion tells me the other, and you run with emotion because it's more powerful. So there's a whole load of reasons that if communication is influenced so much by emotion, that we should really take time to work with it, to read it, and to make it work for us in a way that makes life a little bit easier. Touching on the intensity of emotion that I mentioned there in terms of listening, what we discovered is that when emotion is high, communication actually doesn't flow that well, and we don't have as much of a desire to approach each other and work with each other. When emotion is high, our ears don't work. So actually, the first thing we would do is try to manage that emotion, because if we don't, and we keep talking, we then really don't know how much the other person has taken in. They might take some key points, they might not. But that sender, message, receiver bundle gets a little bit mixed. So we would always try to manage the emotion whenever it cropped up. And what we would be trying to work towards is this equilibrium where logic and emotion is nicely balanced. That encourages us to approach each other, it encourages communication to flow, and therefore it becomes efficient and a time saver rather than trying to communicate through the muddiness of emotionally fueled moments. The next thing I'm going to share with you are the golden tactics. These things that I used to teach as bread and butter to negotiators, but I have to say I promoted them to platinum pretty quick because we use them in every deployment, and I continue to think about them every single day. These are the things that are going to help you make sense of everyone. If we start with where they came from, Roger Fisher and Dan Shapiro were psychologists attached to the Harvard negotiation project in the 80s. And while that might seem a bit dated now, I promise you they are as valid now as they were then. And they uncovered these 5 things and said, every single person on this planet, so that is 7.7 billion people, all need core emotional concerns to be met in order to feel content and happy. So if we know that communication flows when we're content and happy, and that we're encouraged to approach each other when we're content and happy, and these 5 things are a jigsaw puzzle that when put together creates that environment, then why wouldn't we use them? And what I'd like to do just now is go through each of them one by one, and then after that, speak about how we use them and how you can perhaps use them, because they're absolutely fabulous things for taking these shortcuts. Let's talk about them one by one, first of all. Core emotional concerns starts with appreciation. And every single one of us, the people that you haven't even met yet, your patients, your peers, your supervisors, everyone needs to feel appreciated. We need to feel valued by those that we expect to value us. And I suppose while we're going through these core emotional concerns, I'm going to ask you to think of your working environment. And if you come to work with a skip in your step and you really enjoy being part of your team, you're going to recognize some of these core emotional concerns as being met within that environment. If work is a real challenge for you at the moment, if it's really tough, and maybe it's not to do with the people in the team you're working with, but what's been forced upon you through COVID, then you'll find these core emotional concerns have been challenged, and you'll recognize them in that. So it's maybe worthwhile, it'll make them real if you can actually put them into your own situation as we talk through them. Everything starts with appreciation. And this isn't just us being needy. This isn't a nice to have. This is 2 very smart guys saying that the whole planet needs to feel valued. And if you don't get that from somewhere, our emotion will change, we'll become tetchy, we'll be uncomfortable, and we'll actually need coping mechanisms to balance them out. So appreciation, there's actually a language of appreciation, and there are 5 elements to it, which I'll talk through. So I will speak a little bit more about being valued than I am going to be on the other 4, but that's because this is an easy win for everyone. Think of how you feel appreciated at work. Where do you get that appreciation from? Who gives you that? Do you take it from yourself as well? Do you self-speak and tell yourself you've done an okay job, or are you self-critical? And I only highlight that as a question more than anything, because actually we have to feel appreciated. So what are the 5 things? Well, one is verbal, and that's pretty much a a given in most situations. Most people will respond to and feel valued when they have a verbal thank you, for example, albeit thank yous have to be authentic. They're really authentic when it's not just the thank you get, but it's the thank you for. And super authentic if it's thank you for this, I noticed. The I noticed part not only builds into appreciation, but also the feeling that we need to feel important. So thank yous need to be authentic. Verbal is just one. Another one is time. Imagine your line manager taking 10 minutes just to say, we have not caught up in ages, let's grab a coffee and just chat. And if that happens for you, then that in itself will fulfill a part of your need for appreciation. So time. Service is another. If you can do something for someone as effectively a gift, perhaps I work with you and you're really busy and I decide while I'm filing one day, I'll just complete your filing tray at the same time. You can see that that would maybe make you feel valued because I've done something on your behalf. And I mentioned gifts. That is another language of appreciation. And quite often you'll have people who will give gifts to say thank you. And I suspect patients perhaps when they leave a ward may hand in a box of chocolates or a box of biscuits or something just as a token of appreciation, or a handwritten card. All of these things, they boost our emotion into somewhere positive and they fulfill that need to be valued. And the last one is touch. And thankfully, you are in a profession where touch is okay. And you can imagine if you've had a tough day, your colleague just putting their hand on their shoulder and saying, you did all right. That touch adds to that feeling of value. So there are 5 languages within appreciation. It's also the language of love, by the way, just as a sideline in there. But anyway, we'll use it as the language of appreciation today. The next one is autonomy. We need to feel that we have a freedom to say what we need to say, behave in a way that we expect that we should, within the parameters of acceptance. We don't want to feel that we've been backed into a corner. And if you think of it, in the last year during COVID, there's not one of us who hasn't felt our autonomy being challenged at some point. We need that freedom. The next one is affiliation. We migrate to areas where we feel, amongst people that we feel that connection, that human connection with. If you think of it, think of all the people that you're friendly with. You all have a lot in common. The people that you'd rather not be around, you have a lot to differ about. So affiliation, we're drawn into an environment where we feel safe, where we feel secure, where we can actually be vulnerable. And that vulnerability word, again, that can bring a connotation of weakness, and it's not. Actually, vulnerability is incredibly robust because it's the ability to be human, be transparent, but without losing credibility. And if you're in an environment where you can be that vulnerable, it's actually a very empowering place to be. Maybe not always easy at work, but there is an advantage if you can find that balance. The role is next. We need to know not just our job description, although that is important, but we also need to know in the bigger scale, what's our life goals? What do we stand for? What are we working towards? What is our purpose? And if we don't know that, our emotion changes and become a bit tetchy. But it also fits into your reputation. Are you the organised one, the tidy one, the joker of the pack? Are you the maternal or paternal one that looks out for everyone? If you have a reputation and you live up to it and people know that that's what you stand for, it's very comforting for everyone around. And then the last one is status. We need to know that we are accepted for who we are, even though that we're imperfect. That imperfect way that we are, that unconditional positive regard that said, it's okay, I accept you for who you are. The fact that you walk into a room, you're noticed. When you walk out of a room, you're missed. That sort of feeling. So that's core emotional concerns in a nutshell. So how do we use them? Well, first of all, within negotiation, we use them in a couple of ways. If we were in dialogue with someone and everything was ticking away quite comfortably, we would know automatically that core emotional concerns were balanced. But if something was mentioned and it triggered someone's fear or anger or uncertainty that brought in a robust reaction, then we would go to these 5 core emotional concerns as a shortcut. Rather than trying to fathom out what these words triggered and why in great detail, we'd sort of know that actually I've maybe just made him feel unimportant. I've maybe just made him feel isolated rather than affiliated somewhere. Just think of someone leaving dirty coffee cups in the office. Why is that annoying? Well, probably because it makes you feel undervalued because you always end up cleaning them, or unimportant, or really not part of the team because as a team we've agreed to be clean and organized, and you're sitting out with the team leaving your coffee cups. Who knows? But it's worth just touching on these to work out and try and make sense of situations. Any environment that fulfills our core emotional concern need, we will migrate towards. So as a team, how can you fulfill and create an environment where people feel appreciated, feel that they have the freedom to be who they need to be and want to be, and work within the parameters that they're given, to be connected and be themselves, be safe and vulnerable within that environment, that they know their role, what they're working towards, and how they fit into everyone else. And above all, they're noticed when they don't turn up for work, they're missed terribly, and they're welcomed when they come back. If we can create an environment that fulfills these core emotional concerns, then people will want to work with us all the time. Now, that's not just colleagues, patients, folk at home, your friends. Within every organisation, there has to be a hierarchy. There has to be a CEO or a director at the top. There has to be frontline practitioners and various levels of management and specialisms in between. That's entirely right. But when it comes to communication, there's no place for hierarchy or specialism. We need to communicate as human beings, and it's that communication that allows us to sort differences. And when it comes to core emotional concerns and having something that's fit for the future, then that little tactic will serve you well for the challenges now and the future ahead. Why? Because it's attached to human behaviour and emotion, and that's not going to change for a very, very long time. I'm going to finish with a task for you. I'd just like you to consider, what can you do to create an environment that supports core emotional concerns for yourself and for those around you? And I promise you it's going to be an investment. I look forward to any questions that you have shortly, and here are my details if you ever want to get in touch. Thank you very much.
Okay, thank you very much, Kathy. That was brilliant. That was an excellent talk, and I appreciate your time to come and speak to us today. It's an impressive CV you have. I'm impressed with your background in terms of hostage negotiation, and that was an excellent talk, sort of exploring more about the environments and how to improve our work environment. I'm just going to encourage any of the all of our attendees to please put your questions in the chat, and we can moderate them and ask them as they come through. But just to kick things off, I suppose my first question would just be about what's your experience of healthcare, and what have you identified in terms of communication, either with nurses or doctors, or what do you think that something that we could improve our communication?
I suppose one thing that has consistently come out, and I appreciate I've been at everything from conferences to small workshops, and the consistency that comes out is sometimes people are scared to speak up. Mm-hmm. People, respectfully, understandably, there's the hierarchy of responsibility and roles. But within that hierarchy, while that stands, just as I mentioned in the presentation, while that stands absolutely adequately and appropriately for the job that you're doing, when communication is wound into that hierarchy, it makes people scared to speak up. And there will be times when you are within a tense situation that maybe someone who considers themselves to be less experienced, perhaps in a lesser role, will not feel comfortable speaking up to someone because of the role that they hold. So that's the one thing that consistently comes out from any department in any area that I work, is that creates an environment where communication doesn't flow. So my recommendation would be just to consider, well, what can you personally do? And I don't mean just yourself, but if everyone listening to this says, what can I personally do to ensure that I am approachable? What can I do to help that? And at one conference, to put this into perspective, I asked for who consider themselves to be the most senior in the room, who consider themselves to be the most junior in the room, And at that, I says, would you feel comfortable trying to correct? And the immediate question was absolutely not. Now, the senior member of staff was, well, why not? I mean, I'm human, I'm okay, but no, I can't. So until you start understanding why communication doesn't flow, it won't flow. So it's worthy of a conversation and a question.
Thank you very much. So I've just got a question from Tara Bartley, who's one of our leads for ANPs. She says, what would your key advice for being heard be? So this is, I suppose, in a way, we're talking about hierarchy. Tara is one of our fantastic ANP leads and really does, I've seen her encourage her junior nurse practitioner colleagues really well. But so the question is, what would your key advice for being heard? And I'll probably make that the only question just because we're running a little short on time.
Do you want me to come in?
Yes, please. Yes, please.
Okay. It depends. Create the culture that allows people the freedom of speech. Whether that's tactics, I don't know if anybody's heard of CUS or not, but it is something that you can Google and find out about. And I know it's within medical where I'm concerned, I'm uncomfortable, safety and stop, CUS is called. Some people use that as a shortcut. So you might have tactics to be heard, it might be a culture, but if you feel that your voice is not being heard, then you're going to have to find something personal, how to go about that. And it might be, if you remember that every conversation has to have a purpose, and it either falls into spontaneous or planned. If you're going to bring up anything spontaneously, it will always be emotionally fueled, and you're going to have to manage emotion around it. And it does mean that when emotion is high, our ears don't work very well. So if it's important for you to be heard by someone, try not to do it as a surprise. Plan that talk, and then plan what you want to say, why you want to say it, and explain it in that way. So you could, I'd maybe say to yourself, could we possibly have a chat tomorrow over coffee? I'd like to speak about just how I'm being heard in the department, or how I feel that sometimes I have something important to say and I'm not sure how I get it across the right way. And sometimes you can actually ask the people you're trying to get the message to say, what's the best way for me to speak to you in order to be heard? And providing it comes out as a respectful way, that might be quite a good tactic. Dignity has to be at the centre of every communication exchange. I can promise you, you can talk about anything, providing you feel worthy in each other's eyes at the end of that conversation. So retain dignity and be brave and go for it.
Thank you very much, Kathy. That was excellent, and got a lot of praise for you from in our internal chat. And I'll hand it over to, and we really appreciate your time coming to talk today. So I'll hand over to Julie and Emma to introduce the next speaker.
Thank you. Yes, I'd just like to reiterate my thanks to Kathy, and it was a fantastic presentation. So I'll just hand over to Emma now, ready to start our abstract presentations this afternoon.
Sorry, apologies, I was on mute. So the first abstract is from Helen Holmes, who'll be talking about telemedicine. Is this the future of post-cardiac surgery nurse-led follow-up?
Telemedicine, is this the future of post-cardiac surgery nurse-led follow-up? My name is Helen Holmes. I'm a cardiac surgical care practitioner. I work at James Cook, Middlesbrough. Objectives. Face-to-face outpatient appointments were halted from March 2020 to help protect staff and patients from the inevitable spread of COVID-19. Established nurse-led surgical 6-week review clinic was therefore carried out via telephone appointment. Feedback was used for a service evaluation to evaluate the new service concept and improve ongoing telephone consultations. Methods. We used feedback surveys distributed retrospectively to consecutive post-cardiac surgery patients recruited during the month of April 2020, following their routine 6-week nurse-led review by telephone. This was done initially by email, then by letter, then telephone call. Via yes or no responses, questions were grouped to assess quality of the phone call, whether patients' concerns were adequately addressed, quality of the advice given, and patient preferences. Exclusions were made if they had attended a face-to-face appointment. This was usually if the patient presented as symptomatic, whether they required a post-op echo or chest x-ray. Results. The study population consisted of 80 patients. 71 completed the survey. 2 were excluded. This was unfortunately due to COVID-related deaths. And the 7 remaining either declined or were non-respondents. Results. The analysis of the quality of the telephone calls demonstrated a 98% positive response. 93% of the patients felt that their concerns were addressed and good quality advice was given. 55% of the patients felt that the telephone call was the preferred means of contact rather than a video call or face-to-face appointment. 75% of patients felt there were advantages associated with this method of follow-up, namely its convenience due to reduced necessity of travel, whilst also accommodating their state and sense of vulnerability. Conclusions. The telephone appointment achieved its aim of protecting the vulnerable cardiac surgical patients and minimised risks to staff during the first wave of COVID-19 pandemic. Due to the ongoing pandemic, the telephone review appointment continues. With further refinement, this will be offered as an option post-pandemic. A few comments from the feedback from the patients. Questions?
Hi, everyone. Oh, thank you, Helen, for that. That was really interesting, especially as a cardiac surgery nurse practitioner. It's really interesting to gain insight from a nurse-led clinic, firstly, and then onto a telephone. So that was brilliant. Thank you. There's a question that's come through the chat from Lyral, who is also an advanced cardiac surgery nurse practitioner.
Okay.
So she's asking about whether your nurses had previous face-to-face appointment experience. So prior to taking over the telephone, was that something you had experience in, or was this brand new service at the time?
No, actually, yeah, it's been going for quite a while, actually. I think definitely over a year we've been just doing nurse-led follow-up reviews at the 6-week point. Just unsupervised as well. So, it was pretty well established, actually.
That's fantastic. That's really exciting, actually. And I wanted to ask you about the video call option as opposed to the telephone call. Do you think the preference was because of the population, that perhaps an older population? Was there anything that you could pick out from that theme there? Because I would have thought a video consultation might have been preference to some.
I definitely do think it definitely has something to do with the age of the patients, and obviously not being as good with technology, etc. But yes, a telephone consultation, it worked really well, and it actually continues to do so. They're just more comfortable.
Great. And did you have to call people back? Were they unavailable? For your first telephone, did people miss the calls? Was there any problems that you encountered with that as well?
Yeah, well, initially when it first set off, we did have like appointment times, and sometimes the patient might not be in, and we'd have to follow it up, and also if we weren't happy, if we were going to bring them in for something, then you would also continue and you would give them a call a week or two later just to see. So there's a lot of continuity as well. But yeah, there was a few sort of teething problems initially, but it runs pretty smoothly now.
Fantastic. I'm going to contact you outside of this, Helen, I think, to pick your brain, because this is something that I'm very interested in developing in our hospital in Bristol. So
no
it was really insightful. Thank you, Helen.
Absolutely, you're welcome.
Thanks a lot, Helen. Great to see you again.
Hi, Manraj.
And I think we've probably just come to the point where we need to introduce the next speaker. But just quickly, from your perspective, Helen, just anecdotally from your side, did you actually prefer it from your side as well?
I think the general consensus from the team actually is we miss the face-to-face. It's great to see them face-to-face. It's more personal, and yeah, we do miss that element. But obviously, for the patients from Cumbria, completely understand that a telephone call is much more suited, especially if they've recovered really well and progressed fantastically. Then yeah, it just saves that 4-hour round trip.
Great. So I think that's probably, just to keep time, I think we'll hand back over to Julie for our next presentation.
Sorry about that small delay. I'm really delighted to welcome Liu Haijian, who's going to talk to us next about the wound clinic and patient management during COVID-19 pandemic at St. Bartholomew's Hospital and the St. Bart's experience. So welcome to Liu, and I very much look forward to your presentation and subsequent questions from the audience. Thank you.
Good afternoon, ladies and gentlemen. Today, I would like to share with you wound clinic patients management during the COVID-19 pandemic period in St. Bart's Hospital. To be precise, the first wave of COVID-19 pandemic period. First of all, a little bit of background introduction. So, wound clinic in St. Bart's Hospital has been established for many years. It's proven to be a very effective way of managing post-op surgical wound complications. It has helped to manage and prevent the severity of surgical site infection, and more importantly, it helped reducing hospital readmission rates. So the wound clinic is run by our group of surgical care practitioners. It's twice a week, every Tuesday afternoon and every Friday. The wounds we are dealing in the clinic are mainly post-operative surgical wounds. These include sternotomy, thoracotomy, thoracoabdominal wounds, and also as well as groin or leg or chest drain wounds. So the aim of this research is to identify how patients' wounds were managed post-operatively during the pandemic period, and also to explore the feasibility and the effectiveness of remote management of wound clinic. So what we did is we collected data for 6 months period retrospectively, ranging from March the 23rd of 2020, which was the day Boris Johnson announced a national lockdown for the first time in the UK, to September the 23rd of 2020. We also collected data for patients for the total number of patients seen in this 6 months period, including face-to-face or patients who were managed remotely. Also the treatment or intervention they received and the duration of their attendance. So for the face-to-face patients management, in the beginning of the pandemic, we know very little about the virus itself, but we do know that physical attendance to the outpatients clinic can put patients at significant risk of spreading the disease. So we had to adapt to a new way of work very, very quickly. And we also had to implement some measures to ensure patient safety, as well as staff members' safety. So we designed a questionnaire for COVID-19. We screened all our patients irrespectively the day before their appointment day. We normally use a telephone to call them up and ask them if they had any symptoms of dry cough or shortness of breath or temperature. On top of that, we also extended the traditional half an hour patient appointment slot to 1 hour slot. This is to ensure patients have enough time when they come to the clinic to check in and to go through the triage process, and also to ensure there is sufficient time in between patients for cleaning. For patients who were not able to attend the clinic physically, or for those who we do not think require face-to-face intervention, we managed this group remotely. So we have a wound clinic telephone, including a landline number and also a mobile number they can call up any day during the week, not just Tuesday and Friday. And also we have an official email account they can communicate to. Also another WhatsApp, official WhatsApp account for the wound clinic, if they prefer to send the pictures of the wound via WhatsApp. So in this way, we keep regular follow-up and updates with our patients, so we can assess the wound regularly. So the 6 months data revealed a significant drop in total patient appointment numbers. So all in all, 251 patients' appointments were issued during the pandemic period. This is in comparison to the previous 475 appointments 6 months before the lockdown. So out of the 251 appointments, 149 of them were seen face-to-face in the clinic, and 102 were managed remotely. I know these numbers might seem a little bit high, but we have to stress that some of our patients are repetitive. For example, some patients might have long-term sternal wound complications, resulting in them attending the clinic for a long period, maybe more than 2 months or 3 months period. So out of the 149 face-to-face appointments, 61% of them required negative pressure wound therapy, such as pickle dressing or back dressing. 24% of them progressed to sternal wear removal, and 14% of them required only minimal intervention, such as dry dressing. So in conclusion, we established that the implementation of remote management contributed to a reduction in face-to-face visits of wound clinic. And the data ultimately showed the advantage and feasibility of remote management. And we believe that with a more rigorous triage process in place, more and more patients could be and should be managed remotely. So therefore, the shifting of traditional face-to-face wound clinic to the remote or virtual clinic should be the way forward. Thank you.
Thank you so much, Helen. That was an excellent presentation with regard to wound clinic in this era. And again, you're echoing some of the points that we just had about telemedicine moving on. Again, if any of the attendees, please do pop your question into the chat. So the question I've got for you for the first one was there a conversion from people who were being seen remotely into a face-to-face? So was there a few people that initially you were seen by video or phone call, but then would turn into a face-to-face?
Yes, there are some patients. So we managed remotely at first, and then because we contact the patients frequently, updating with, they normally update us with photos and video calls and stuff like that. So sometimes if we feel the wound needs further interventions, we do bring them in, but we try to do the maximum over a remote measurement.
Just whilst we're waiting again for potential questions, my next question would be: Did you like it? Was there appreciation from it from doctors who these patients were, and also from the SCP, ANP teams? Did you actually prefer increasing the remote consultations that you were doing?
Yeah, so actually we do see the remote way of wound clinic is actually working. So at the moment we try to share the workload, because traditionally we manage most of our patients face-to-face. So regardless, we normally ask them to come in, because sometimes the wound, it's better to assess them face-to-face, so you have a better idea what's going on. But because of the pandemic period, we had to adapt to the virtual clinic, and actually we see it's actually feasible. So we see some of the patients can be managed remotely. So we try to convert at least some of the patients remotely.
Okay. Thank you very, very much. I'm afraid we're going to have to make that the last question. My apologies to our attendees. So I'll hand back over to Julie and Emma to introduce the next question. Oh, the next presenter, sorry.
That's all right. Thank you very much, Helen. And I do apologise that I introduced your name incorrectly. It's written the other way round on my sheet. So sincere apologies for that. But superb presentation, and thank you very much indeed. Excellent. Emma?
Thank you.
Lovely, thank you. So next up, it's my pleasure to introduce my colleague, Elena Eden, who's going to be discussing a review of physiotherapy input for patients following their routine cardiac surgery. So over to you, Elena.
Hi, thank you for coming to my presentation on a review of physiotherapy input for patients following routine cardiac surgery. My name's Elena Eden. I'm the physiotherapy service lead at Royal Papworth Hospital in Cambridge. I'm also the ACPRC surgical champion. We developed a screening tool for cardiac surgery patients a few years ago. The premise was that if patients triggered on any of the dimensions on the screening tool, they would receive physiotherapy treatment. If they didn't trigger on any of the dimensions, then they did not require treatment on day one. The screening tool was developed on the assumption that patients would pass through cardiac recovery on day one and therefore would be mobilised by the physio team on the ward on day two. We reviewed the screening tool in November 2013, and we found that 62% of patients screened in at that time. We refined the screening tool in 2018, removing BMI because we found it wasn't an independent trigger factor for post-op complications. We also added in the balloon pump and inotropes because patients were staying in cardiac recovery for up to 48 hours, therefore not moving through to the ward and being mobilised on day one. At this point, we found that 47% of patients screened in. We made a change in October 2018, reflecting that the nurses who worked on cardiac recovery had a brilliant level of skill and experience and were quite often highlighting to us the patients that they thought needed physio, which very closely aligned to the patients that we had already screened in using the screening tool. So we were both doing the same role and come to the same conclusion. However, the nurses, having been with the patient throughout the night and for the morning, knew the patient's needs much better than we did. It also came at a time where we had a lot of physio vacancies and we needed to look closely at realigning our resources, basing the available staff with patients who would improve with physio and not over-treating patients who would recover without too much physio intervention. We performed a retrospective audit of patients' notes from October to December 2018, and this was 304 patients. And we found with the change that only 18% of patients required physio treatment. Out of the patients who were referred, we found that they had a lower average PO2 and a higher FiO2, which you would expect because most of them were being referred for physio treatment. The other reason they were mainly referred was for assistance with mobility. So we looked at the past medical history of the patients, and unsurprisingly, the ones who required physio, respiratory physio, tended to have respiratory complications pre-op, and those with neurological or orthopedic prior issues would be referred for mobility. We looked at what type of banding of staff were treating patients, and it was mainly the band 6 physios and our band 4 assistant practitioners. And these band 4 assistant practitioners have been upskilled to be able to read x-rays, assess cough effectiveness, and provide basic respiratory and rehab lung volume, increasing lung volume treatments to post-op patients. Unsurprisingly, most patients were seen for deep breathing exercises, coughing, mobilising to the chair and marching on the spot. We've continued this way of practicing with the nurses referring patients to us. We no longer cohort patients, but we still wait for the nurses to refer the patients to us. However, they are now continue to be seen on day 2 on the ward every day till discharge. So the next step is to review this practice and again align resources to patients that require physio. So if patients will recover without too much physio intervention, we can withdraw with some of the routine patients and provide more input with the slower recovering patients. However, we must remember the impact on our stakeholders, because if we withdraw our service, this may impact others. My conclusion is that a change to referral service for cardiac recovery patients has led to fewer patients requiring physio. I think this is a reflection of better pre-op education, post-op optimization, leading to less post-op complications, and the excellent skill of our nursing staff. I'd like to thank Tom Walker and Florence for helping with data collection for this. I am the surgical champion for the ACPRC, so if you are a cardiothoracic physio and you want to get in touch to start networking, please do contact me on either of these email addresses. Thank you for your time.
Great. Thank you so much, Elena. That was really interesting. Always useful to get insight from our AHP colleagues as well about the whole patient journey and patient experience. So thank you. While we're waiting for any questions to filter through, I had one. I had a couple, if that's okay. But I'm sure I'll get interrupted. You were talking about it being nurse-led or nurse referral service. So did you have to spend a bit of time investing in those nurses prior to starting this so that they were fully aware of the criteria? How much time did you have to put into that to set it up in the first place?
Well, it's a while ago now, so it's probably, this ball started rolling probably about 10 years ago. So yes, there was a training program to explain to nurses what we would normally cover and just ask them to run through sternal wound precautions, check a patient's cough. And to be honest, we'd already evolved into a cohorted area where the nurses were doing it. So part of our thought to pull back was we knew we'd go up and we'd tell the patients these things and they were nodding. They already knew it. They'd already been told this. So yes, there was an education package, but it was more reinforcing what they were doing already. So.
And were you involved in the pre-assessment point of that as well? You were talking about the patients seemed more educated in what was expected of them and what their part in their recovery was. So how much input did you have in the prehab aspect of it as well?
So a long time ago, we used to attend pre-admission clinic and we'd do a talk in person each clinic, but that's evolved into a DVD, which is obviously now available online. But I think the changing point was we changed many years ago from the language of we are here to help you recover to you are the central person of your recovery. And the DVD now we have of that is very much the patient is the master of their recovery and we're there to help, as opposed to kind of us doing all the work. And I think that pre-op education, and obviously we're not involved with the clinic now, but we're referred any patients they're concerned about. So yeah, I think it's been a change of education with the video and the supporting material.
I think that's valuable, actually, isn't it? Is reminding those patients that they are the key person in their own recovery. So that's a really useful point. Thank you. I have got a question that's come through here on the chat. Do you see all post-op day 2 patients? And if so, how do you decide on what band would review them?
Yeah, we do at the moment. Well, we do depending on the day of the week. So this is another area for us to look at because it's quite a difference. If they're operated on a Monday, we screen them out on Tuesday. They're reviewed on a a Wednesday. If you're operational on a Thursday, screen out Friday, we see you the following Monday, unless there's any complications that require weekend treatment. So that already is something that our team will be looking at. We have a brilliant cohort of Band 4 practitioners, and so as long as there's no reason a registered physio needs to see them, the Band 4s would tend to take most of the cardiac surgery patients, which then gives the registered physios a opportunity to see the more complex patients, respiratory patients, some of the transplant patients, thoracic patients, etc.
Great, thank you. That answers that question brilliantly. Thank you so much for your time, Elena. Really interesting. And I'll pass back to Julie now, who will introduce our next speaker.
Excellent. Thank you very much, Alana. A really interesting presentation, and delighted to have that on our programme this afternoon. So thank you. I'd like to introduce Trixie Arsegono from St Bartholomew's Hospital, who is going to talk to us now about training theatre staff in a single site speciality hospital for robotic thoracic surgeries. Welcome, and we very much look forward to your presentation and subsequent questions. Thank you.
Good afternoon. On behalf of my colleague Ms. Bryony Hopper, I am here to share with you a service improvement project at St. Bartholomew's Hospital Theatres entitled Training Theatre Staff in a Single-Site Specialty Hospital for Robotic Thoracic Surgeries, a retrospective analysis and a discussion of training strategies. In September 2017, our department commenced the preparations for the launch of the first robotic system dedicated for cardiothoracic surgeries. The preparations not only included logistical aspect of things, but it has also emphasized the need for facilitating effective transition of theater staff members to becoming adept with the Da Vinci Xi surgical system. We have collaborated with intuitive clinical representatives in building a training plan for core robotic team. The initial robotic training scheme was inclusive of immersive learning experience at off-site robotic teaching centers, theoretical training videos and online assessments, and hands-on training sessions and practice simulations with intuitive clinical representatives and extended multidisciplinary team. From the first robotic surgery performed in November 2017, the authors conducted an evaluation of the aforementioned training program. This service evaluation aimed to explore the relevance of initial training plan designed by assigned Da Vinci clinical representatives, identify key themes, and thereafter promote effective learning strategies in assisting theatre staff to adapt to a new surgical technology and specialty. Our methodical literature review revealed that a secured environment and appropriate level of support are essential in closing identified staff training gaps. Furthermore, an equal need to update practitioner skills is necessary whenever new technological advancements are introduced. Training schemes such as in this project ensure patient safety while also promoting staff professional value and role development. Three key themes emerged from staff evaluation of the training scheme: knowledge, safety, and empowerment. The respondents stated that they were able to achieve a sound understanding of basic components and stages of robotic surgery, troubleshoot minimal issues when required, and confidently react during emergency conversions. However, it has also become known that other aspects of the training program were regarded by staff as unnecessary at an early stage learning. Instead, they have highlighted that emergency protocols need to be simulated at a regular basis and more learning exposures be secured. Our service evaluation project emphasized the importance of a supported learning environment for theatre staff members. It had led to the inclusion of a structured robotic training program in thoracic surgical competencies for scrub nurses, allowing them a minimum of 75 hours protected supernumerary staff rotation in robotic theaters with agreed signed off. Opportunities for specialized trainings are given to scrub team leaders on off-site training centers. This specialized training program given to scrub team leaders allowed them to spearhead and monitor the training program of scrub nurses and healthcare support workers. Emergency and doc training sessions with intuitive clinical sales representatives are organized twice yearly at a minimum. This ensures safe and efficient emergency undocking procedures based on communication and coordinated teamwork. Since its development, 50% of cardiothoracic scrub nurses and healthcare support workers have formally completed the structured in-house robotic training program and are now fully equipped to participate with the increasing service delivery.
Thank you very much, Trixie. That was fantastic. I thought that was a great thing about, in general, about new technologies when we're bringing them into the hospitals. For example, with mini mitral as well, where you've got to take a whole team forward with this. My question for you was really about was whether the team at Barts, you're going to consider publishing this as a model of excellence of introducing new technologies. Specifically, if you've heard of the GERFT initiative, the Getting It Right First Time, and that's been a way of trying to spread models of excellence in different units. Is there any plans to either publish this as a model of getting new technologies, or trying to disseminate this further for any other units trying to look at robotics as well?
Thank you for that sentiment, Manraj. At the moment, if I were to be honest, there are no specific plans yet of sharing this effectiveness or service evaluation program, but obviously through this conference and through joining other conferences, we would be able to communicate all of these efforts.
Great. I've just got a question from the audience from Nicola Ria. She says, this is very exciting and innovative development within your department. When the program launched, did you come across any challenges? If so, how have you overcome these challenges?
Definitely. During the initial phases, more of the sentiments were focused on the logistical approach of establishing a new team, but we were able to negotiate and emphasize the connection and direct impact of training theatre staff members into achieving a full-on safe and effective transitioning of competencies from scrub nurses and its impact on patient safety.
Okay. I mean, another question, I was quite impressed that you managed to get it was 75 hours of minimum time to get signed off. Was that quite difficult in terms of getting management to agree to that level of time for you, for the staff?
Definitely. They were a bit adamant in terms of training theatre staff members, but also we were quite critical in allocating staff members with the other cases that the theatre is catering to. So that was a hurdle for us. But with establishing good relationships and communication with the managers, we were able to secure great buy-ins from them, and we were able to secure this 75 hours time period of supernumerary status.
Yeah, I think that's a real achievement for the whole department to really go through, and it's a brilliant uptake of the technology over the last few years. Hannah, have you got any sentiments or comments or questions that you want to ask?
Yeah, well, interestingly, I was thinking about your protected time actually, coming from clinical experience, and just was really impressed that you managed to get that, because we struggle with protected time in all of our roles, don't we? So I was really impressed to hear that. So thank you for sharing your experiences. It was really, really helpful. Thank you.
Thank you for this opportunity as well.
Trixie, that was an excellent presentation, and we really appreciate your time to come and present for us. I think we'll try and get ahead of ourselves in this case, and I'll hand over to Emma to introduce our next presenter.
Lovely. So our next presenter is Ian Mcpherson, who will be talking about virtual cardiac clinics during COVID. Are they the new normal?
Good afternoon, my name's Ian Mcpherson. I'm an ST2 cardiothoracic trainee at the Freeman Hospital in Newcastle, and I'm delighted to be asked today to present our study looking at the use of virtual clinics in cardiac surgery. Before we begin, I'd like to just declare on behalf of myself and my colleagues that we have no conflicts of interest. As a brief introduction, we're all aware that COVID-19 has dramatically changed how we practice medicine across all specialties this year. Many clinicians have adopted virtual patient conferencing technology to allow us to continue to assess patients, see patients, and deliver healthcare and services. However, this is a particularly new development in cardiac surgery, and quite rightly there will be questions which remain on the safety of its use and how we can use this going forward. A bit of background to virtual clinics. This is not a new technology. It's often referred to as telemedicine, and it's been used commonly in areas where particularly geography makes face-to-face consultations difficult. And as a trainee of a Scottish university, we use this very commonly when assessing patients from the Highlands and Islands. There are three main ways to use this: synchronously, which allows us to communicate in real time, which is what we're talking about with this study, in an asynchronous way, so it's when data, images, or any other information is recorded and shared with a health professional at a later time, or remote monitoring, for example, if a patient has their weight taken or the blood pressure taken, this is then sent forward to the clinician to review. There are clear pros, which reduce travel time and cost, and it helps to widen access to healthcare for many patients, and particularly this year, the reduced risk to patients with COVID-19. There are downsides as well, which is that we can't examine patients virtually in a way that we normally would. There are connectivity issues and data security issues if we aren't careful, and also ease of use, particularly not stereotype, but for some of our older patients who maybe don't use the technology routinely in the way that we do. Our aim is to assess the use of video conferencing technology in cardiac surgery with regards to the satisfaction of both the surgeon and the patients using it. Methods is a prospective analysis of all virtual clinic appointments for one surgeon between the 1st of April 2020 and the present day. This included both new and follow-up patients. We had a dedicated webcam and microphone on both sides for the surgeon and the patient, and we used the Attend Anywhere software. The patients were sent dedicated instructions on how to access their appointment 1 week in advance, and all patients were consented to participate with both the patient and the surgeon filling out a questionnaire for each encounter. Results from the patients: 110 consultations, 70 or just under 2/3 of these were follow-up, 40 of these were new pre-op assessments. Looking at the questionnaire, only one patient, less than 1%, had any connection issues, and 96% were very satisfied with their experience. Just under 90% preferred seeing a clinician with no mask on virtually than to in person with a mask on. But 100% so all their questions were answered in a similar way to seeing a clinician face-to-face. 110 patients, 100% liked the convenience in being at home, and 96 liked the ability to involve support easily, and it was important to all participants to be protected from COVID. For the surgeon, we're able to examine wounds in 100% of patients, and that we're able to gather all the information appropriately. General impression was that pre-auth information was conveyed easily in the same way as a face-to-face appointment, but we're unable to obviously examine patients, particularly for AF, or get an accurate weight, and this leads to reliance on local GPs to review and assess these continuing needs and convey this information to the tertiary service. Overall, 91% would use a virtual clinic again if offered, and 91% again thought it was better than or the same as a face-to-face appointment. Particularly, the benefit of reduced travel time and cost was repeatedly cited as a reason to like virtual clinic appointments. In conclusion, it's a high satisfaction for both clinical staff and patients. The ability to communicate without a mask was appreciated by patients. There was no reduction in information gathering ability. Issues remain regarding the ability to examine a patient, but will always be the case with virtual clinics. And should we offer patients the option between virtual and face-to-face appointments in the future, it's a very real possibility that this is something that we will do. Thank you very much.
Great, thank you, Ian. So that's the talk we've had about virtual clinics today, and it's obviously the way forward, and definitely changing our thinking about moving forward and how we're going to liaise with our patients. I have a couple of questions. Is Ian here?
I think he was, but he's
having a
connection
issue, isn't he? I think.
Yeah.
Should we give him a chance to see if he can reconnect there?
Yeah, I suppose we'll just wait for it.
We can move on and we can come back to maybe questions at the end when he has some connections, just so that we can keep up with time a little bit. We've just got a message, he is having connection issues. So with that in mind, I think it would be, I
think he's trying.
Yeah, it's looking good, yay!
Hi, are you there? Can you hear us?
Might be a bit slow for him, I think.
Let's see.
Apologies, everyone. We're just seeing if we can try and get hold of Ian just after that talk. It would be great to just hear from him.
We seem to maybe have lost him. We'll just try. Are you there, Ian? I think maybe he's having difficulties, and maybe we'll move on. So really sorry that we can't get to pose your questions to him this afternoon. But if we can get him back, we'll add on at the end or at the next break if we can. With that in mind, I'd like to introduce Paula Silva, and Paula's going to talk to us this afternoon about improved crisis resource management in post-operative cardiothoracic emergencies using in situ simulation. So welcome to Paula, and we very much look forward to your presentation.
Hi everyone, my name is Paula. I work as a practice educator in a nurse-led post-anesthetic care unit at Royal Brompton Hospital, and I will be presenting a project developed by myself and colleagues in March 2019 regarding the improvement of crisis resource management skills within our team using in situ simulation. So I will start by introducing the project and explaining the background that led to it. So throughout the years, we've seen a rise in the amount and complexity of our patients, which led to the need of develop and implement educational projects to develop the skills of our staff. Among others, this led to the implementation of a pilot cardiac advanced life support in June 2018, and other changes within the hospital, including the standardization of the CALS trolley. Myself and other colleagues, having attended the CALS training, we also attended a simulated interprofessional team training course, or sprint, which enabled us then to start a program in March 2019 and deliver high fidelity in situ simulation to our team. The aim is to develop the technical and non-technical skills of the team, and we aim to conduct it monthly. So this includes the delivery of high fidelity in situ simulations that were recorded for future visualization and team reflection. We aim to include all healthcare professionals involved in managing post-operative cardiothoracic patients and covering the most common complications and emergencies, including advanced life support and cardiac advanced life support. The most important part was the debriefing, in which we include advocacy inquiry questions to promote the team reflection regarding their weaknesses relating to the practice and developing strategies to overcome these weaknesses in the future. We used two tools to assess the feedback. The first one was a feedback form aiming to analyze the levels of confidence, motivation, and learnings of the team. So the data that was analyzed revealed the consistency in terms of confidence parallel to an increase in attendance. The team was motivated to attend and were able to explore individual and team weaknesses and strengths. Also, the team monitor tool analyzed the crisis resource management skills, and we have seen a consistency as well in terms of the crisis resource management skills throughout the simulations and an improvement of all the domains. In terms of reported feelings, we could analyze enablers and also the barriers for the learning, which were related with levels of stress and how difficult it is to deal with emergency situations, but how important it is the level of support received from the senior team, senior nurses, the senior doctors dealing with emergency, and the importance of leadership, and also the amount of experience and its impact when we are dealing with emergencies. In terms of reported learnings, those consisted mainly in three areas. So the practice to prepare for real life emergencies, how important it is to have this exposure. The other topic was their awareness of protocols and algorithms. And the last one was the learning and how important it is to have a reflective practice in terms of our strengths and weaknesses to aim to improve. So to conclude, the results obtained so far are promising, reinforcing then the need to carry on delivering monthly, whenever possible, the sprint program in order to carry on updating knowledge, skills with evidence-based practice of our team. Thank you so much for your time.
Excellent. Okay, do we have Paula?
She here?
For her questions? Oh, excellent. Excellent. Welcome, Paula.
Thanks, Paula. That was a really good presentation. Just for housekeeping, we're just going to do Paula's questions and then for 3 minutes. Then I think we've got Ian back, so we'll try and do his questions afterwards. So that's a brilliant expansion on, I think, the traditional CALs that I think a lot of us have been involved with. I was particularly interested by the non-technical skills part. I'll ask my question first, if that's all right. It was just really about the focus of non-technical skills. Was that spilled over into the realm of sort of other things where it's not related to the emergency situation? So in terms of when you're on the ward and there are sort of peri-arrest situations, has that helped learning, have you noticed, sort of anecdotally?
Yes, absolutely. We've been focusing on non-technical skills like communication, for example, a closed loop communication to help people to try to get into the habit of reporting back what was asked for them, which is really important in an emergency situation to avoid either two people, for example, doing the same task or a task being left undone. So that was a very good and very important pillar for our sprint simulations, as well as leadership and role allocation. Try to implement the role allocation and understand the resources that you have, the skill mix of your team to improve the team work and manage more successfully an emergency. And in parallel, we focused in a variety of emergencies, and we as well went through the protocols, we reviewed the protocols, so we also focused as well on the clinical skills of the team. So it was a combination.
Great. I've got one question from Lil Jacob, who's from Bristol. Can you please expand on the term nurse-led unit? How many beds was this? What level of what level were the patients? I think obviously referring to whether these are level 2 patients or level 1. And then was this completely managed by nurses or under the supervision of medics?
Yes, of course. So our unit is 10 beds, 8 adults and 2 pediatrics. And our patients are either level 2 or level 3 patients after cardiothoracic surgery and cardiology. Nurse-led unit means that we work together with anesthetists, with the surgeons, in terms of having plans and protocols, but the unit is led by nurses. Our unit is our nurses are very skilled, and together with the support of anesthetists and surgeons, we deliver the best possible care to our patients.
Thank you very much, Paula. I think Hannah's probably got some burning questions because we're trying to set up a similar nursing-led unit. But I think for the sake of making sure that we're keeping to time, I'll hand over to Hannah. I very much appreciate your time, Paula, and that was a brilliant presentation on sort of an advancement of how we should be developing CALs more than just simply the clinical skills, which is just a really important thing for modern era medicine. And so I'll hand over to Hannah for questions for Ian. I'm hoping Ian might be back.
Sure, yeah. Is Ian?
Ian, are you on to join us for your questions? Ian, we're looking forward to welcoming you to the main stage. Bit shy, possibly, but after such a brilliant presentation, we're really looking forward to speaking with you. Excellent.
There we go.
Excellent. Welcome. Good afternoon, Ian. Oh. This is the SCTS best kept secret. Ian, we can see you. We can see you.
It might be worth switching off your video, Ian, perhaps, and just audio. It might be better.
Yeah, that might work.
Oh, having a thunderstorm in Newcastle.
Oh, no.
Oh, well, we can't compete with the weather. That would be very tricky. Ian, what we'll do is I think we'll continue. We'll see if the thunderstorm passes. But we do have a couple of questions for you. So actually we'll put them in the chat and maybe you can respond to them in the chat and we can bring them out at the end. If you were able to hear that. So apologies to the audience that we haven't been able to bring you questions for Ian, but we have a slight change to programme this afternoon in that we have an added bonus presentation for you, free at no extra charge, you'll be pleased to know. And so I am delighted to welcome Daisy Sanderman to the stage, and she's going to talk to us about Acorns to Oak Trees, the evolution of the Cardiothoracic Forum. So welcome, Daisy, and we very much look forward to hearing from you about the development of the SCTS Cardiothoracic Forum, and no doubt something about its future. Are you there? Excellent.
Good afternoon. I'm Daisy Sanderman, the meeting lead for SCTS CT Forum, and thank you for giving me this opportunity opportunity to share a little bit of the history, the legacy, and a reminiscence about the SCTS CT Forum. I wanted to find out where it all began, and on investigating a little bit more, found out that in 2004, the surgeons in the society felt it would be good to involve a nurse in the society to understand what else happens in the profession and join them with the society. So Jacqueline Nichol, who used to be the lead nurse in cardiothoracic surgery at NHS Greater Glasgow and Clyde, joined the society in 2004. In 2005, she attended the SCTS meeting in Guernsey for the first time in the capacity of a professional nurse and as part of the SCTS platform. Today, Jacqueline is a site director at NHS Ayrshire and Arran. Moving on a little bit more is when we all start to remember and identify the SCTS that we know of today. Dame Tara Bartley was interviewed and appointed in the post of the lead for nursing and allied health professionals for the SCTS in 2006. And Tara remarkably continued for 2 terms, which ended in 2012. During that period, Tara, a visionary that she is, made sure that CT Forum was an integral part of SCTS. Her main emphasis was on advanced practice, education, which involved the cardiothoracic and advanced life support. Tara continues to be invested in professional nursing collaborations, including the Royal College of Nursing, and is at present working in Brighton as a corporate lead for advanced clinical practice. Moving on a little bit more, Christina Bannister joined the society as a lead in 2012 and continued up till 2017. Christina brought another dimension to the meeting and the society. Christina, who works as a nurse case manager in Southampton, continued with the national and international collaborations of the society and was a pioneer in involving patients with the society and got also involved with charitable ventures like the Heart Valve Voices and Heart Research UK. Helen Mundy was appointed in 2017 when Christina Bannister, Chrissy, stepped down. Helen, who used to be the matron in the Royal Papworth and presently works in St. Bart's, continued with international collaborations, spoke at privileged platforms internationally, and also invited guests likewise to attend and speak at our meetings in the last few years. The main vision of Helen used to be getting involved, involving the grassroots levels, and she always mentions that to be the biggest drive to get membership and more participation from the members within the society. And due to her intensive work with going to different centers and informing and spreading the word of SCTS, Helen has managed to have the highest number of membership registrations to the SCTS. And this also led to creating a few subcommittees within the society, within various specialties, and that has strengthened and got from various levels of improvement under the leadership of Helen. Helen also was very keen in involving the allied health professionals and their representation within the society. And then a very unusual and surreal thing happened to all of us, COVID-19. And during the pandemic is when Helen transitioned out and Dr. Bhuvana Krishnamurthy joined the SCTS as our present lead in February 2021. Bhuvana's background is a surgical care practitioner And Bhuvana believes in leading by example and is very honest that she wants every single advanced practitioner to perform according to the pillars of advanced practice, which emphasizes a lot on research and leadership besides clinical and education input within advanced practice. Bhuvana's vision remains to have increased allied health professional representation within their CTS, and extra feather in the cap is very, very topical and something that we all strive to achieve and have been working very hard to maintain is equality and diversity. So this is the beginning of Bhuvana's tenure and leadership. We are all looking forward to see where we head. The future is bright, and I believe this is just the beginning of what is in store for the society, CT Forum, nursing and allied health professional group within the society. I want to quote Isaac Newton here, who said, "If I have seen further, it is by standing on the shoulders of giants." And these four remarkable women are nothing but extraordinary giants who have led us to where we are today. But as I mentioned before, this is just the beginning, and the future looks extremely bright. This is Bhuvana's little tribute, and we all support Helen as she steps down from her tenure as the lead for nursing and allied health professionals. We wanted to put together a collage of all the fantastic and wonderful things that Helen has been involved in the last few decades, especially the one in the middle where she achieved the climb to Mount Kilimanjaro. Helen is such an example and a leader who motivates everyone by being part of everything she believes in doing, and with a friendly smile, with a compassionate manner. And we will miss not having Helen as our leader, but I'm sure the society is in extremely wonderful and safe hands with Bhuvana leading us forward. Thank you for listening to me.
So congratulations to Helen there, sorry.
Yes, complete congratulations to Helen. You can now see why we wanted you to come in and direct the questions at the end. So, as Daisy very eloquently said, we couldn't give you the praise and the recognition and the thanks for all that you have done for the SCTS Forum last year, as we would normally have done, or again in February. So this is a delayed, very, very much so, but we didn't want the opportunity to pass us by entirely. So thank you to Daisy for putting it all together and getting you under false pretenses to join our communication session, which I think is a very apt session for you to join on the basis that it was about present challenges and future vision. And it was certainly the current challenges that prevented us acknowledging all that you've done over your 4-year or 5-year kind of tenure with us. So I think I will like to thank everybody that's taken part in the session, but I do think the final words really for this bit should come from you.
Oh, well, bless you. Thank you so very much. I am truly touched, and that was a surprise. You have to think about the pictures that you put on social media for sure. That was lovely. Lovely to see some of those pictures again. So thank you for that. And I mean, what I absolutely have to stress is this is by no means a one-man show. I mean, it's thanks to the remarkable people that we surround ourselves with, both at work and within the society, and testament to all the work that has gone on before that has got us to where we are. And actually, it was lovely, Daisy, seeing your slides of back in mid-2000 where it really began, and actually where my involvement began. And I still remember very, very clearly, and I often say this, but I remember being asked by a consultant colleague when I attended the society meeting for my first time, and was attending one of the sessions in the one of the main sessions. And he sat down next to me and he said, "Helen, are you in the wrong session?" And I said, "No, absolutely not. I'm here. I'm a co-author on this paper, and I'm here to hear the presentation." And it seems incredible, actually, that that we should even be asked that question. We all have a seat at the table, and I'm so excited about what's to come, because it is absolutely phenomenal. So thank you to everybody. Thank you very much.
Thank you, Helen. Thank you. Definitely. And so that brings us very nicely and remarkably completely on time. So I can only thank my absolutely superb co-hosts this afternoon who've done a tremendous job. So thank you to Emma, Hannah and to Manraj for keeping me sane and keeping everything together. And I'd like to thank Kathy MacDonald for a superb plenary session. Thank you very much indeed. And most of all to the audience, thank you very much for your company and for listening and for your questions. And hopefully you'll stay on for the webinars that are on later on this afternoon. So thank you all very much indeed, and what a lovely picture of everybody on stage to end the session on. So thank you very much and have a wonderful afternoon.
Thank you.
Bye-bye.
Thanks, bye.
Thank you.